For decades, when we think about diagnosing obstructive airway disease, one thing comes to mind: spirometry. But what if there was another way? What if we could get a really powerful clue about obstruction using a tool that's, well, already right there at the bedside, the ultrasound? In this explainer, we're going to break down a pretty fascinating paper by Zan Farlin and his colleagues that proposes a new, non-invasive way to do exactly that, just by looking at how the diaphragm moves.
All right, here's how we're going to tackle this. First, we'll look at the incredible parallel between an ultrasound trace and a spirometry curve that really sparked this whole idea. Then, we'll get into the nuts and bolts of the M-mode index of obstruction, or MIO technique. After that, we'll dig into the key findings from their study, unpack the physiology behind why it works, and finally, we'll talk about where this fits in clinically, both its uses and its really important limitations.
So, let's set the stage. We all know spirometry is our gold standard, right? It gives us these precise, hard numbers on airflow. But it takes a cooperative patient, it needs special equipment, and you can't always just whip it out at the point of care. So the authors of this study asked a really brilliant question. Could the way the diaphragm moves, something we can see with ultrasound, act as a sort of proxy?
And this slide right here, this is the aha moment. Seriously, take a look. On the right, that's the classic volume time curve from spirometry we've all seen a million times. But now look at the left. That's an M-mode ultrasound of the diaphragm during a forced breath out. The resemblance is just uncanny. That steep initial drop, followed by a gradual plateau. It's like you're literally watching the FEV1 and the vital capacity play out in the diaphragm's movement.
This wasn't just a cool little observation. This powerful visual similarity became the entire conceptual launchpad for a brand new, quantifiable way to look for obstruction, the M-mode index of obstruction.
Okay, so how do you take a visual pattern like that and turn it into a hard number, something we can actually use clinically? Let's walk through the technique.
The technique itself is actually pretty straightforward, especially if you're comfortable with basic POCUS. You have the patient sitting up a bit, you grab a low-frequency probe, an abdominal or cardiac probe works great, and you place it in the right subcostal position. You're going to use the liver as your acoustic window, angle up, and get a nice clear view of the dome of the right hemodiaphragm. Then you just hit the M-mode button.
So from that M-mode tracing, we get our first measurement. It's called FEV1. That stands for Forced Expiratory Diaphragmatic Excursion in the first second. And this is our direct ultrasound equivalent of FEV1. All it is the vertical distance, measured in centimeters, that the diaphragm moves upward in that very first second of a hard, fast exhale.
And our second measurement is EDMX, or Maximum Expiratory Diaphragmatic Excursion. You can probably guess where this is going. This is the stand-in for vital capacity. It's just the total vertical distance the diaphragm travels from the very peak of inspiration all the way to that end expiratory plateau.
And here's where it all comes together so elegantly. Just like we calculate FEV1 over VC, the M-mode index of obstruction, or MIO, is simply FDE1 divided by EDmax, and you express it as a percentage. It's a beautiful parallel that tells you what percentage of the diaphragm's total journey happens in that critical first second.
Now, a clever idea is one thing, but you gotta ask, does it actually hold up? Does it work in real patients? So let's look at the data. The study compared these MIO measurements in a group of healthy people against patients with known spirometry-confirmed obstructive disease.
And yeah, the results were pretty dramatic. In the healthy group, the average MIO was way up there, around 87%. But in the obstructed group, it dropped down to 67%. And this wasn't even close. The difference was highly statistically significant, with a p-value less than 0.001. That's some really solid initial proof that MIO can tell these two groups apart.
This slide just makes it so clear. Look at the trace on the left. That's from a patient with well-controlled asthma. See how steep and fast that upward slope is? That gives you a high MIO. Now look at the right. That's a patient with COPD. The slope is so much flatter, the movement is slower, more labored, and the MIO is way down. You can literally see the obstruction's effect on the diaphragm. It's incredible.
And the validation didn't stop there. They found a really strong, significant linear correlation between their new ultrasound MIO value and the gold standard FEV1/VC ratio from spirometry. This is huge because it shows that as one goes down, the other tends to go down with it. It's more proof that MIO is truly tapping into the same underlying obstructive physiology.
So what's the number? What's the clinical takeaway? Well,
After running a ROC curve analysis, the study found that an MIO value of less than 77 was the best cutoff to suspect an obstructive pattern. This gives us a practical, actionable number we can use right at the bedside.
And that cutoff performs remarkably well. An MBIO of less than 77 had a positive predictive value of 95.5%. Let that sink in. That means if your patient has a low MBIO, you can be extremely confident that they have an obstructive pattern that's going to be confirmed on spirometry.
Okay, so we've seen that it works. But the really cool part is understanding why. What is it about airway obstruction that physically slows down the diaphragm's relaxation during a forced breath out?
This diagram explains it perfectly. So in a healthy person, when you force air out, it exits fast. The pressure inside your chest drops quickly, and the diaphragm can just relax and rise back up without any trouble. But in a patient with obstruction, the air gets trapped. It can't get out as fast. This keeps the intrathoracic pressure higher for longer, which acts like a brake, physically pushing back against the diaphragm and slowing down its ascent.
And the authors really nailed the summary right here. At its heart, MIO is an index of speed. It's a non-invasive way to measure how quickly the diaphragm can relax against the pressure inside the chest, a process that is directly slowed down by airway obstruction.
So what's the bottom line? Where does this tool fit in our day-to-day practice? And, just as importantly, what are the caveats we need to keep in mind?
Well, the potential uses here are pretty significant. I mean, think about that patient with undifferentiated shortness of breath in the ED. This could be a super fast screening tool to point you towards an obstructive cause. It's a game changer when spirometry isn't available, or for patients who just can't do the maneuver. Maybe they're too weak or confused. You could even pick it up as an incidental finding on a FAST exam or a gallbladder scan.
But, and this is a big but, we have to be crystal clear about the limitations. Spirometry is and remains the undisputed gold standard for diagnosis. This is not a replacement. You also need a decent acoustic window, which can be tough in some patients, and the patient still has to be able to cooperate enough to give you a good forced exhalation. Also, and this is critical, this first study wasn't blinded, so we definitely need more validation to back up these really impressive findings.
So if you remember one thing, it's this distinction. MIO gives us a fantastic indirect estimate of obstruction by looking at its effect on the diaphragm. Spirometry is the direct measurement of the airflow itself. To put it simply, MIO is a screening test, spirometry is the diagnostic test.
And that leaves us with a really interesting question for the future. As point-of-care ultrasound becomes basically the new stethoscope, could a quick M-mode look at the diaphragm just become a standard part of the workup for any patient who comes in short of breath? Based on this evidence, that future feels very, very possible.